Okay, welcome everyone to this webinar presented by the Collaborative Family Healthcare Association. My name is Naftali Serrano. I'm the Executive Director of CFHA. Welcome. For those of you who are members, thank you for your support. Your membership dollars are a big part of what supports the continuing education that CFHA provides. And so this is in large part because you've decided to support integrated care. So thank you. For those of you who are not CFHA members, we certainly encourage you to join our community. Our membership is an annual membership, so it's a good time to sign up for the 2019 membership. For those of you who are members, it is renewal time, so please consider renewing. It's real fast and easy at cfha.net. I'm really happy today to present today's webinar. This is sort of a part two in a way. Ruth and her colleagues presented their work related to the implementation of an ACE questionnaire within their workflow. It was at sort of the beginning stages of what they were working on, which is something that we pride ourselves on here at CFHA. We talk about the things that we're trying out at the early stages and let other people know about it, have people get excited about it, and then we talk about what happened with it and how that all develops. We really believe strongly that learning about the process of how we implement these integrated care efforts are just as important as the actual results. But today we're going to hear from Ruth and also colleagues of her care team. So you're really going to get a sense of an integrated care experience of implementing a particular intervention, in this case, a really important and very cutting edge assessment of the impact of traumatic experiences in childhood. So this is a really cool topic, and I want to first start off by thanking Ruth and her colleagues for being here today and for being willing to share their process with us today as well. I will let Ruth and her colleagues introduce themselves. I will let you know before we get started that you can certainly ask questions as we go. You can use the chat box in the GoToWebinar control panel and provide any questions. I'll be sort of trying to collect those sort of questions as they emerge. But we'll have time at the end, about 15 minutes of time that we'll allot for any questions that people may have, and the presenters will answer those at that time. So without further ado, I'd like to introduce Dr. Ruth Nutting and colleagues. Ruth, take it away.
Thank you, Naftali. So yes, I am the Director of Behavioral Health here at the Christi Family Medicine Residency. I am also a Clinical Assistant Professor at the University of Kansas School of Medicine here in Wichita, Kansas. And I was first informed of trauma-informed care about a year and a half ago. And from that time, I've worked closely with our administration as well as faculty and residents in order to implement a trauma-informed care approach to the service that our patients receive here within our residency.
My name is Dr. Amy Steary. I'm a general pediatrician. I am a faculty member for the Christi Family Medicine Residency Program. Yes, pediatrician working with family med docs. And I'm also an assistant professor at the KU School of Medicine, also here in Wichita, Kansas. As a general pediatrician, I've seen comments about trauma-informed care and adverse childhood events popping up in the literature, but was having trouble coming up with tangible ways to make it a reality of addressing within our clinic. And I'm so incredibly grateful for Dr. Nutting for helping us find that pathway.
And my name is Vanessa Love. I'm a project specialist with the Wichita State University Community Engagement Institute. And my role in this project, fortunately, is funded by our state health department, which allows me to provide training and technical assistance to public health partners across our state that are interested in becoming more trauma-informed and trauma-responsive in their services and practices.
All right, so we have 4 primary objectives today. The first will be having Vanessa Loaf identify the impact of ACEs on long-term physical and mental health outcomes. We'll also be providing an overview of our targeted patient population and the implementation process of the ACE-Q. We'll be spending the majority of our time today highlighting providers' perspectives of screening for ACEs, and I'm really excited because we have a guest speaker with us today, Dr. Macy Whitbrett. She is one of our third-year family med residents, and she is here to share her personal and professional experience of really embracing a trauma-informed approach to healthcare. And then we'll be finishing the webinar today with discussing our next steps.
So we're going to just very briefly get started by refreshing everybody's memories about adverse childhood experiences and environments and how they impact long-term physical and mental health. I know that a lot of you are probably familiar with the ACEs science, but some of you may have students with you and other folks that may be new to this, and so we're just going to do a quick introduction before we get started talking specifically about the work that Via Christi's been doing. So what we know is that adverse experiences and toxic stress are pretty much kind of an invisible and not talked about part of long-term physical and mental health. We know now that it dramatically increases the risk for 7 out of 10 the leading causes of death in the U.S., affecting the nervous system, the immune system, and various hormonal systems in the body, and even in some cases changing the DNA and the epigenetic impacts that we are seeing from generation to generation. It can triple the lifetime risk of heart disease and lung cancer, and in some cases reduce life expectancy by up to 20 years. As you may know, that the science started more than 20 years ago now with a study that was conducted by the Centers for Disease Control and Kaiser Permanente that was actually done in an obesity clinic in California in the late 1990s. And that study had a focus on 10 very specific types of adverse childhood experiences. But what we've continued to learn and what we know in our practices is that these 10 are not the only adverse experiences that our patients and their families deal with. But when those experiences are combined with a lack of protective factors and some predisposed vulnerabilities, we can see that a chronic dysregulation of the nervous system, the endocrine system, and the immune systems, leading to any number of physical and behavioral health challenges, including those epigenetic changes that I mentioned earlier. So if we have moms that are pregnant, it's impacting the babies in utero, and then we start to see these challenges become more and more prevalent generation to generation if we don't intervene and have those protective factors to buffer. For children in particular, because of the sensitivity in their development, if this stuff happens in certain times and key windows in that development process, we can see growth delay. So some of our failure to thrive babies may actually be a response to toxic stress, not necessarily just a nutritional issue. It could see cognitive delays, things like sleep disruption, and when babies aren't sleeping, neither is anybody else in the house, and so then we start to see that stress compounded throughout the family. As the kids get older, we see more and more issues in the community and in the classroom. We see more immunological diseases like asthma and arthritis, problems in school, and then as they get older, the risk continues to increase of adopting those high-risk behaviors like smoking, violence in school, teen pregnancy, all of those kinds of issues, if we're not doing something to intervene early. As I mentioned, we have more recent data that is showing how adverse childhood experiences and environments can impact the top 10 leading causes of death. And I think very few of you likely are surprised by the increased risk in suicide, because people associate that with adverse experiences. But the one that we find people are most surprised by is number 6 there, Alzheimer's, where the risk is increased 11-fold for those folks that have experienced 4 or more ACEs. That's a really high number, especially when you consider heart disease, chronic lower respiratory disease, and diabetes all could also be connected to high-risk behaviors like smoking or not eating properly. Alzheimer's may not be as influenced by that. And so that's giving us even more data about the impact that stress is having in those areas. The CDC has named this issue probably the #1 public health issue in our lifetime. And back in 2012, the American Academy of Pediatrics issued this statement encouraging primary care practices to leverage the science that continues to develop in order to develop strategies that interrupt this cycle. One of those strategies is screening for ACEs early and often, just as one small part of providing trauma-informed primary care. I'm going to turn things over to the rest of the team, and they're going to be able to tell you a little bit more about how Via Christi is doing that.
Yeah, so this is Dr. Siri again, the pediatrician. So certainly, it would seem very obvious, very much a sense of common sense that we would want to know the kinds of trauma that our patients are experiencing so we can address it. But finding a way to effectively ask about it that's not re-traumatizing, finding ways to then intervene in a successful manner, it's all very nebulous and sometimes very difficult, I think, as a clinician to find the next steps forward. So we'd love to just kind of refresh you on our implementation steps. First, it's nice to know kind of our setting. We are located in the urban center of Wichita, Kansas, which is a population of about 400,000 within city limits. We have 3 physical clinic sites. 2 of those are our family medicine residency clinics, and then our 3rd site is what's known as the pediatric specialty clinic, and that's also resident staffed. And within that population, we're serving what you would normally expect with the residency clinic, a lot of underserved patients who are on Medicare and Medicaid. Obviously, in our PEDS clinic, we have a higher predominance of Medicaid patients as well.
All right, so to provide a brief overview about the initial implementation process, I really focused on collaboration among every type of personnel within our clinic setting. So as I first mentioned in the beginning of this presentation, I initially got administrators on board with trauma-informed care and screening for ACEs. In August of 2017, Dr. Siri, Vanessa Loaf, and I met with one of our clinical managers, along with a research expert and an IT specialist, in order to determine how we were going to effectively begin screening for ACEs. And that was a really insightful meeting to hear from different team members in developing a direction that was going to be feasible for us. Following that meeting, we joined the National Pediatric Practice Community, and we registered as a pediatric specialty clinic, which would be screening. So this provided us further resources and also indicated us as a pediatric clinic here in Kansas screening for ACEs. We also adopted an ACE-Q protocol for staff and physicians. So this was a very important piece of the training process. And the original protocol was provided by the Center for Youth Wellness. Following that, I created a referral sheet that was specific to ACEs. So there's one section on that referral sheet which identifies supportive services in the community focused on development, another section that focuses on mentorship within the community, and then a 3rd section for therapeutic services within the community. We certainly have the patients with significant ACEs referred to our behavioral health team here, but we also wanted to make sure that we were pulling from the resources that we have available for patients in the community as well, so that each patient would be provided with what they needed. And then lastly, we completed a project description and a research application. We received exempt status a couple months after filing for that, as this project was considered regular clinic operations. So once we received that approval from IRB in December of 2017, Vanessa Loaf and I then had the task of further educating the residents here as well as staff. So I want everyone to know that our residents had received training last year specifically on trauma-informed care and ACEs. Vanessa Loaf and myself had provided 3 different presentations during didactic. So our residents were familiar with this, but we wanted to specifically train them on how to screen, what this process would be like, and what the referral process would look like. So Vanessa came and provided 2 separate trainings. Each training was identical, but we wanted to capture all of our 54 family med residents as well as 24 core faculty within those trainings. And we were able to do that successfully. We did have 6 family med residents who were not available to attend those in-person trainings. So we did video record one of those trainings, and those 6 residents were able to view the recordings online. We also needed to train our support staff. So within the pediatric specialty clinic, we had 13 personnel to train, and these personnel had not received training on trauma-informed care or ACEs prior to this. So Vanessa Loaf provided a 90-minute presentation, and she also did this over a course of 3 different presentations in order to provide education to all 13 staff members. So in order, if we were going to screen for ACEs, we needed to have resources available. As I had mentioned earlier, we are often referring to community resources if we feel like a resource in the community is going to be a better fit for a patient or a family. But we also have our own behavioral health team, which has expanded over the past couple of years. In 2017, the behavioral health team included myself as the director, and then we had 2 master's level interns. As our expertise has been utilized more and more within the pediatric specialty clinic as well as our regular family med clinic, we were aware that we would need further behavioral health expertise in order to provide our patients with the services they needed in our clinic setting. So last year we did recruit doctoral interns. So now we are a program of 4 behavioral health providers.
So as a clinician working alongside Dr. Netting and our support staff, when we decided to go live, as was mentioned before, we were using the Center for Youth Wellness ACE-Q form, the actual screening tool, and looking at the different options within those screening tools. They had younger children and they had a teen version filled out by parent, and then also a teen version filled out by the teen. What we elected to do, since we were rolling out just within the ped specialty clinic first, to try to do this for limited ages. And I was trying to pick ages that I thought might be more likely to show up, mostly because of well child checks and needed vaccines. So we decided to use the screening tool for children for ages 4 and 11, and then the teen screening tool, but the completed by parent version for the ages 16. So we were able to, over a couple of months with this pilot, get about 184 patients seen, and we were also at the same time able within our workflow to figure out how to better load this into our EMR. We worked with paper versions first, and we got an electronic health record version within our chart, so it would be easier to audit the population and individuals as well.
All right, so we have been screening for ACEs since April 16th of 2018, so just about 6 months. And in September through October timeframe, we wanted to evaluate the first 6 months of screening. And so we looked at the data, and we knew that going into this, between the ages of 4, 11, and 16, we would be able to screen a total of 184 patients at their well child exams each year. In the first 6 months of screening, we had completed 54 screens. There were additional 6 patients where their caregivers had refused the screening. Of those screened, there were 12 patients that had either a score greater than 3 or relevant symptomatology. 5 of those patients were referred to our behavioral health team here. 4 already had community support, and then 3 caregivers declined referrals. So Dr. Siri and Vanessa and I met in August, and we were like, well, okay, we can do more. We have the resources available. This has not been overwhelming in any way. And so at that time, Dr. Siri and I decided to start screening all children ages 4 through 18 at their well child exams. So we are going from 184 potential screenings per year to 1,445, which is an increase of almost 80%. So we're excited to see what our findings will be in the next 6 months and to know that we are screening and intervening with more patients.
We also kind of wanted to wrap back around and to figure out how everyone was perceiving the project so far. And I took on the task of discussing this with our staff members, and I actually got a lot of surprising responses I wasn't anticipating. I felt like staff fell into two camps on very extreme ends. I wasn't anticipating some of the negative response that I was getting, but a lot of it was coming from kind of a staffing issue to a degree, like I'm sure many clinics can relate to, and feeling that this was an extra part of workload in their daily flow of tasks and not necessarily having the same kind of buy-in that we had hoped for. Some of it was just fatigue of the amount of screening forms that they have to go through with every well child check and the numerous things that are expected on the checklist. There were a lot of them that even yesterday were complaining that, well, it's just a study, right? We just have to get this over and done with. And it's like, no, this is our new workflow. This is our new way of being as providers. And we may take the data to do studies in the future, but a lot of staff providers, it sounded like, were just telling families, well, you can fill it out if you want, but it's just a study, and weren't necessarily following the dialogue that we had hoped for. I also felt that what I was seeing in clinic wasn't necessarily matching up with the numbers of what we were recording fully, that there were quite a few forms that were maybe getting declined or not picked back up by the provider, the residents or myself, on the far end within the clinic visit, and come to find out that staff was aware of this, that they're like, oh yeah, I've seen parents hiding the form or wanting to not turn it back in or lying that they've completed it and don't know where it went. And so we were seeing that because families might have had some apprehension, staff felt even less engaged to help families complete this. But I did see a lot of very positive responses. One staff member who works at our front desk, who is very engaged with this topic, just had the most wonderful conversation with me, and I tried my best to summarize her statement. It's too easy sometimes to judge people by their behavior, especially when you don't know about their past. And I hope I've done her justice in that summary. But she felt with trauma-informed care, it was easier to approach these more tense situations with recognizing its behavior, it's not the person. Look past the behavior and try to help the person. And they really loved that this was, again, a way to ask families about some very intimate details, but without making them relive that horrible trauma. We also got some physician perspectives, and I was going to just read one to you. You can certainly read the others on the slide. I was very impressed by Dr. Traxler, one of our PGY1s, with his statement. I think the expansion will be beneficial because by screening for ACEs, we will be able to identify more children at risk for major health diseases and hopefully continue to work towards intervening and helping these children grow into healthy adults. I love that this perspective came from an early training resident in family medicine who, of course, is going to be responsible for his patients through their lifetime. And he is already recognizing the impact he can have at a young age of his patients by early intervention when these issues are identified.
All right, so I will follow up with faculty perspectives. And again, I will not be reading all of these, so please take your time to read through them. But first and foremost, I want everyone to know that I did not prompt these responses. It might feel like I did, but in no way were they prompted. And I was really excited to pick up on the themes between all of these quotes, in that our faculty are excited that our residency program is recognizing the effects of ACEs, but going beyond recognizing. We're doing something to make a difference, to hopefully increase positive health outcomes for these patients over the lifespan. I'd really like to highlight Dr. Jennifer Wipperman's when she said, having the ACE-Q implementation has been eye-opening in the frequency of patients that have difficult and traumatic experiences. While this may be disheartening, it is rather hopeful in the readily available care made available through our behavioral health team and the early impacts that can divert young patients from the road of ensuing poor health outcomes toward an avenue of resilience and empowerment. I absolutely love that Dr. Wipperman picked up on the resiliency piece here. So yes, we are looking at these adversities in order to help our patients receive a buffer to promote resiliency and long-term positive coping. And we follow those perspectives up with our behavioral health providers. Again, take your time to review these. I was excited to receive these from my behavioral health team, specifically Janelle Hartwell's, who identifies it is deeply rewarding to see firsthand how early intervention can positively impact an individual's biopsychosocial trajectory. Offering trauma-informed intervention gives patients a better chance at a healthy future and can potentially interrupt the transgenerational cycle of trauma. In other words, it feels like changing the world one ACE-Q at a time. I really respond to that transgenerational cycle and breaking that, because we know that behaviors are repeated. We know that coping styles are repeated. And to break a negative pattern of behavior or negative pattern of coping is so important in order to provide youth and adolescents more opportunities and positive chances for their long-term health outcomes. And then to also identify, changing the world one ACE-Q at a time. I really like that positive way of looking at this intervention. So now I'd like to turn it over to Dr. Macy Rubrecht, who is going to share some of her thoughts in regards to this implementation of the ACEs screening.
Thank you, Dr. Nutting. Yes, I was really excited last year when Dr. Nutting and Vanessa Lowe first introduced the ACE questionnaire to us and gave us the trauma-informed care training. I first heard of the ACEs study when I was in high school, and it was fascinating to me. And I just saw it come up throughout undergrad and then medical school and even in residency training, how much trauma and people's past can really play into their health and development. So the fact that we were starting to do something about it and really addressing that was really important to me. The idea became very clear to me when I was in medical school. I was doing a psychiatry rotation at a state hospital, and so many of the patients had horrible traumas, and I was just like, I can't believe we're not even addressing this really. And but the tides have turned, and I think in the last several years, the medical community has really started to identify this more and more. So I was really excited to see how it's being played out, and I'm looking forward to see how being proactive and developing our clinics into being more trauma-informed providers will have on our patients' future and overall development. Throughout my residency training, I even started to begin noticing how my own history and my own traumatic experiences in childhood were affecting me. So this area in particular is very dear to my heart, and I'm really glad that we're starting to look into it more and starting to develop ways to help our patients improve their health and improve their ability to develop resilience and overall general healthy lifestyles. That it's not a death sentence, and it's not, well, this is where I came from, so this is what happens. No, we can change our patient's trajectory. So I'm really excited to see that. I think it's going to be a game changer in the next several years as hopefully more and more clinics really jump on this bandwagon and take it more seriously and learn to develop ways to implement it into their clinics.
Thank you, Dr. Rubrecht. So I'm curious, you're in a residency setting that is currently focusing on trauma-informed care, screening for ACEs. How are you going to take the knowledge you've gained into your next setting where you'll be practicing in just a few months?
Yeah, so funny you should say that. I was just interviewing in Philadelphia, inner city Philadelphia, where that clinic experiences trauma every single day, all the patients. And I had asked them, I'm like, well, what are you doing about addressing the trauma? And I was surprised to hear that the clinic was like, well, yeah, we recognize that it is very important, but we don't really have anything set in stone. It's kind of a work in progress. So it was kind of interesting, and I'm hoping to definitely implement it, whether it is using the ACE questionnaire or just being more diligent about taking trauma histories with my patients, and hopefully helping whatever clinic I end up working with become more trauma informed and really jumping on that bandwagon. And I think our residency program is great in the fact that we have an integrated behavioral health department. I think that's been really helpful in terms of addressing the trauma needs, but also then like the behavioral implications that result from that.
Thank you, Dr. Rupert. So lastly, Dr. Siri and I are going to highlight our next steps. So we would like to expand screening to our family medicine side, which overall has a larger population. We will pilot it on the family med side like we did within the pediatric specialty clinic. And so we will start screening ages 4, 11, and 16 at their well-child exams, which will be an additional 819 screens per year, potentially speaking. So again, we'll be reviewing our resources and ideally expanding our behavioral health program even more within the next year.
Yeah, another step that we're thinking about is we're trying to be very receptive to the feedback we're getting from nursing staff. Again, kind of that form fatigue and maybe overburdening. I'm also noticing a trend that maybe if families are declining to fill out the ACE-Q, we don't have a great script or dialogue yet to respond to that, but that maybe if the answers are coming more directly from the physician, it might feel a little more worthwhile. I can tell as a patient myself going through, when I keep getting asked questions or filling out forms, sometimes it doesn't feel personal and necessary. So maybe reconsidering our workflow when the forms are distributed or when they're collected, we're going to play around with that. Also, it's nice to have redundancy within a system. If for some reason the form isn't on someone's chart, we're hoping to update the well-child check templates within our electronic medical record. So there's also a secondary prompt to make sure the residents are asking, looking for the forms, discussing the results with those family members.
We also want to start providing more emphasis on resilience. So a lot of times our patients are already somewhat stuck in this problem-saturated narrative, and when screening for ACEs, they may feel like, oh my goodness, I have even more adversities than I realized. And so what we want to do is we want to recognize those adversities, but we also want to recognize how those patients have gained resilience. So we may be doing that more on the follow-up side within traditional psychotherapy in regards to incorporating the resilience inventory. This would specifically focus on adults, and they would be identifying who they had in their life as a mentor, what protective buffers did they have in order to decrease the long-term negative effects of those adversities. We'll also be looking more at resiliency building blocks for children and adults. For children, we'll be targeting how they can best develop self-esteem, appropriate ways to demonstrate empathy, encourage and support them in developing appropriate communication skills relevant to age and development. Also focusing on building a trusting relationship with these children and helping them to learn self-advocation. Very similar blocks for adults as well, in, again, helping them feel empowered to ask questions or share ideas, helping them to increase their overall self-esteem, learn how to maybe ask or accept help, and again, of course, increase trust. So we really want to embrace that resiliency aspect as well, because that's where the hope comes in for our patients. We want to continue educating our family med residents on ACEs. So each year that we have a new incoming class, they are now receiving the ACEs training during orientation. But we want to do more, and so Vanessa Loaf and I typically have 1 or 2 presentations throughout the year on trauma-informed care and ACEs. And in addition to that, I have recently started to require our residents read Dr. Nadine Burke Harris's book, The Deepest Well, Healing the Long-Term Effects of Childhood Adversity. And they're required to read that on their behavioral health rotation. And what is most exciting about that requirement is that originally the requirement did not initiate from me. It actually initiated from one of our residents who I had shared the book with her, and she appreciated reading it so much. She felt that everyone should read it, and I was obviously in agreement of that. So that is now a required reading that they can learn more about ACEs and how they can better support their patients with ACEs.
And my apologies, I meant to bring up a point earlier, and some of you may already have this question of why we have families that are declining to fill out the form. And some of the things we've started to notice already, kind of backtracking to that topic, is that if they fill out the form, some families are actually worried that we might use that information against them, make a referral to Child Protective Services, for example, or be in judgment of their family. We know that it's possible that some of the parents are being triggered by looking at these forms and remembering their own personal traumas and how high their own score might be, or even just in a sense of embarrassment that their child does have such an elevated score. Those are just a few that we've encountered to date, and we're hoping to continue to track the ones that are declined, maybe finding out why that's happening. So sorry again for that being out of order. I did want to throw in another amazing point that I experienced in the hospital just this morning. Because our residents are getting this trauma-informed care and exposure to the ACE form, we had a very complex conversion disorder case for a 15-year-old female. And we have excellent psychiatry colleagues. However, they were struggling to find maybe a source for the conversion as a sense of trauma or stress. And the patient continually kept denying any kind of depression or current active stress issues. Unprompted, one of our senior residents went in, did an ACE-Q with this family, and found out this child's been living in chronic toxic stress, but that's her norm, and didn't feel that that was worth reporting. And I won't say this was a breakthrough in the case, but was extremely helpful in creating a more therapeutic environment for that family and helping to resolve her conversion symptoms. Getting back on track with the slide, we are also hoping by trending these numbers over time that maybe we can assess a baseline for our community, our population served by our clinic in general. It would be amazing to compare that to other urban centers in the future and see how we do. It'd be nice to trend over time for individual patients. Are we successfully preventing them from coming into further contact with traumatic type events? If families are willing to work with our resiliency training, is that helping them, not just with the ACE numbers, but then also because we're a medical-based clinic, what are their health outcomes? Are we seeing improvement in things like asthma care? Are we seeing decreases in cardiovascular disease as these patients age? And I think it'd be incredible for us to take this information back to our local community leaders, identifying maybe areas within our city of higher zip codes of stress and need, or looking at the health outcomes we have and working with our health department and continuing to expand this type of training and implementation.
All right. And lastly, we also want to refocus our referral script. So through gathering evaluative information on the pediatric specialty clinic, it was identified that there has been resistance from caregivers to have their children referred to the behavioral health team because there's stigma associated with that term, behavioral health. So we are now asking our residents to change the language that they utilize to say that they would like to refer the patient and family to Dr. Nutting and her team, who specialize in providing additional support in whatever ways the patient or family feels necessary. So it's a little warmer sounding to patients and a little less stigmatizing. So we're hoping to decrease some of that resistance that has been met previously. So that is everything we had to share with you today. So we would like to take the next 15 to 20 minutes to answer any questions that listeners may have for us.
Great. Thank you all. I've had so many things flying through my head, but I'll stick to the questions that are currently listed. And I was wrong. It looks like the question box is where you will put your questions in. So there's 3 questions so far, but keep adding them as they go and I'll read them out. So the first comes from a good friend, Andrew Phillip. So here's Andrew's question. Can you expand on the comment about building resiliency, how this is done, particularly in this setting, and if there's a proactive approach that can be taken with this. So I think the question's getting at, the core of the intervention that you hope to mitigate these issues with.
Yes, so this is something that we'll be looking at more, but overall, really identifying the exceptions to adversity. So what have patients experienced that has helped buffer those experiences of adversity? What positive messages have they received in life? When have they felt empowered? When have they felt like they've had a voice? So really highlighting those instances for patients and building on those and looking at patients' innate strengths and helping them recognize those strengths and utilizing those in order to help patients feel more empowered and to help them move towards making more positive decisions for themselves. We are specifically looking at some tools that are available in regards to resiliency. Vanessa Loaf has recently shared some more resources with me that target resiliency. Do you want to speak to those a bit, Vanessa?
Yeah, in a number of ways, particularly with kids, being able to talk about what they want to build in their toolbox, so to speak. And so some of you may be familiar with the Community Resilience Initiative out of Walla Walla, Washington. Some know them as Resilience Trumps ACEs. They have a number of resources to help have those conversations with parents and kids, to talk about what tools they have in their toolbox and then what tools they would like to have, and identifying those in more of a conversational way rather than having them take yet another inventory. Just having those kinds of conversations and then giving folks the opportunity. It could also be that Dr. Nutting and her team refer a family to a local community resource that can work more intensely. So unless they're being seen for psychiatric or for actual psychotherapy through the team, there may be some community resources similar to what you might have in your community to be able to address that resiliency piece. But just having doctors talk to families about, wow, this is a really big thing in your life, and there are things we can do to help you build up an immunity, so to speak, to the effects of these adversities that you've had. So just changing that language in the conversation will be part of that discussion.
And following up to that, really focusing on mentorship opportunities. So referral source that we have really been providing our patients recently has actually been the Big Brothers Big Sisters program, which is a national program, and that provides kiddos in the communities really long-term support, and that one person in their life can make a huge difference. It can be life changers. So that is an area that we have been referring to more recently.
Great. And I'll just also alert folks on the webinar. I think today's webinar has a complimentary webinar that we did, I believe it was in August, with the Center for Integrated Health Solutions that focused on ACEs with adults and an innovative intervention approach to help ameliorate the effects of ACEs in adults. So you can check that out on the integratedcarenews.com website, again, under the same Vimeo stream that this webinar will be. And it may be interesting to look at both of them and see how a pediatric implementation looks different from an adult setting in implementation.
Absolutely.
So next question here is from Jeffrey. Jeffrey's asking, how difficult has it been to arrange care and or treatment for patients having PTSD or other adjustment issues as identified on the ACEs instrument? At our clinic locations, we find providers uncomfortable with screening because of the shortage of behavioral health providers to take on the patients who are identified as needing care.
Can I just say I totally relate? This is Dr. Suri, and that was one of my huge issues early on, because I was like, well, what's the point of identifying this if I don't have a way of treating it? And of course, then Dr. Nutting came along.
Thank you, Dr. Suri. So Yes, our behavioral health team really does strive to be available as much as possible. We work really within two formats, both the traditional psychotherapy as well as integrated care. So on integrated care, we're available for those brief consults. And even if we're not available to meet with the family face-to-face, residents will typically refer those patients to us and we'll make contact. And through that contact, we'll talk about really the services that we can provide here at the clinic in regards to behavioral health. And in that conversation I have with parents, we determine whether or not a community referral or establishing here with one of our behavioral health providers is the best fit. Oftentimes, families will want to establish with a provider here because they're comfortable here, they know us, and my behavioral health team will meet with patients, and sometimes the overall goal for therapy with that family is getting them the resources they need within the community. So we may meet with those families for a briefer period of time in order to make sure that we're providing the best referrals possible. And so that is another approach that we do take, but we are consistently expanding our program in order to meet the needs of our patients in regards to mental health.
Absolutely. Having that immediate support is crucial, I think, for any of this kind of screening that's very, very emotionally potent. So you guys stimulated a bunch of questions here, so I'm just going to let the folks know, hang tight, your questions will be answered. Tanya, Holly, Melissa, Jody, Yair, Yesenia, and Valerie. So we'll work through your questions here. This is the next question. This is from Valerie. From Seattle. She says, I'm wondering what kinds of interventions and support, this might have been answered, but let me know if you have anything additional to say. What kind of interventions and support the behavioral health folks provided in response to the issues your patients were dealing with? Do you feel like we answered that pretty well, or do you have anything to add to that?
Nothing to add.
Okay. So this is from Yesenia. Do you need training to use the ACE questionnaire? So what's your opinion about whether the training that you guys did, because you guys did a lot of background work on this. I think this is a good question. Should you just start using it, or should you have some training before using it?
This is Vanessa. I really strongly recommend that people have training first. There needs to be conversation in the clinic about, similar to the question earlier about what do you do when you don't have the resources, like Dr. Siri was saying, that kind of conversation needs to happen before you start implementing any kind of screening, not just the ACE-Q. But if you decide to use an ACE questionnaire of some kind, and there are many, we've just decided in this project that the ACE-Q was the one that worked for this particular project. The people who are administering the screening need to understand what ACEs are, because families are going to have questions about why you're asking me this. So they need to have a good understanding of the science and have a good understanding of what a trauma-informed response is. You know, because I told you to is not a trauma-informed response. And so making sure that all of the staff in the clinic have some sort of background in ACEs and understanding of why this is important and how their own, I really appreciated when Macy talked about how she's learning more about how ACEs affect her, because it also, this issue is not a pediatric issue or a patient issue. This is an everybody issue, and how we show up to do the work. And if we just start doing a screening, you might start triggering things in staff that you're not prepared to deal with. And so the training piece of that, I think, is really fundamental before you implement any kind of screening, particularly when asking such personal questions about people's histories.
Yeah, and I'll just second that as someone who did try to cowboy it years ago. We tried to do an ACE screening implementation without much training, and we ran into lots and lots of barriers and had to back up and do a lot of work to fix all that. So second that.
And I would just follow that up with saying, you know, look what resources you have in the community, because honestly, our clinic would not be where it's at in regards to screening, referral, and treatment if it was not for Vanessa and her expertise. She has really helps the process so much and has been invaluable. So your community educators are, and what resources you can pull in, because you shouldn't be doing this all alone, because you will need that additional support.
Absolutely, absolutely. There's a question here as well, and I lost the name of the person, but there's a question about the language of the ASQ and concern about the level of the language. Did you run into any problems with the language for your population?
No, I think that's a great point. This is Dr. Steary again. So, you know, within the population we serve, at least 10% of them will not be able to read to a 3rd to 5th grade reading level, and that's the ones who are native English speakers. So that certainly is an issue. It's one of the other reasons why I've been thinking maybe having the actual medical providers handing out the form or working through the form with the families. It's one less point of embarrassment for someone who's having trouble reading or understanding the form, and a way for them to get real-time feedback and getting those questions answered. But yes, that is always an issue with any screening tool.
Yes. And actually a follow-up that Yesenia has to her question was about obtaining ACE training. I note that in the presentation you guys noted some resources, but where would you send a clinician, whether it's a physician, resident, or behavioral health person, to obtain some training on ACE implementation?
It depends on what state you're in, honestly, but the Center for Youth Wellness, which was founded by Dr. Nadine Burke-Harris, the book that Dr. Nutting mentioned as required reading, they have a ton of resources for clinics, particularly pediatric clinics, but they can be expanded to family medicine and other types of clinics. Their research just focuses on pediatrics. They have a lot of training available on their website. Also, just in the last couple of days, the Center for Healthcare Strategies has launched a brand new website, and it has some training elements in it. And frankly, just a Google search of ACEs science will get you a beginning piece of understanding. But I would encourage you to look within your state. And, you know, in our case, I'm housed at Wichita State University, so we have university partners that are doing this training across the state. You may have similar things depending on what state you're in. Philadelphia is one of the hotbeds of this work in the country, and so if you're in Pennsylvania, the Sanctuary Institute is another really good place to be looking for training. So I'm happy to provide any sort of resources to your folks that they could distribute, but I think those would be some really good places for you to start.
Great. And we have 8 questions and 8 minutes remaining, just so you know.
Okay, 1 minute per question.
Yes. So this is a great question from Yaira. She's curious about outcomes with ethnic minorities, and is wondering if this is something you have been able to do in the clinic, and the differences in approaching the topic with this population, if any.
So with the 6 months that we have spent screening, we don't have any hard data in regards to outcomes at this point. We will certainly have more data and be doing studies in the next 2 to 3 years, so hold tight for those. But we haven't noticed a huge difference in regards to different minority populations or different cultural backgrounds in regards to the actual screening process.
Okay, great. And it's going to be a very important question going forward as we migrant families, for example, coming through with significant trauma, and immigrants here with immigration-based trauma. So we'll keep an eye on that for sure.
Yes, and that is something
Jody
that
has
I
a
would.
question. I'm sorry, go ahead.
I'm sorry, just to add to that really quickly, Naftali, I will tell you that yes, just in the past year and a half, there has been a lot more trauma in regards to deportation. Yes.
Yes. Which, by the way, there's another one of our webinars by Martha Saucedo coming up in a couple of weeks, actually, mid-December, is focused on working with Latino patients and the trauma that they face. So you can check that one out. All right, Jody has a question here about how you administer the tool. Is it a barrier basically to administer basically one-on-one verbally?
So the initial flow within the clinic was distributed by our front desk staff, along with a kind of a script of explanation of why this form was important and what they had to gain for their child by completing it. The nurse was then checking in with families during the check-in process for the well child check and making sure, did they understand the form, were they completing it, did they have any questions, and then the form was left in the room for the physician to come in, gather with the other screening tools, milestone markers, et cetera, and to kind of work through within the course of that visit. By having families hanging onto the form for so long, that's where the quote-unquote getting lost issue was coming in, where we think it wasn't really the form being lost, but more being pocketed or thrown away. Or again, despite these points of contact, physicians were coming into the room and the form was still blank. And so, again, kind of just creating a moment of, well, why didn't you want to fill out this form? Am I making you uncomfortable? So again, maybe flipping this where if the physician's coming in with the form and in the course of the visit, introducing it, being able to explain it, working through it, answering questions. So I don't know necessarily that just a written versus a verbal form is a presentation is better than the other. I'm just throwing out for our group, it may be worth experimenting with.
Great. Melissa Welch is interested in whether there were any observations of trends among other sorts of settings or contexts other than rural, urban. Did you do any data breakdown other than that?
We have not done any breakdown in regards to trends. And when I mentioned the trend in trauma from deportation, that's from me recognizing it and providers recognizing it, but we do not have hard data on that at this point.
All right, that'll be in the to be continued part.
Yes.
So this is Hernan's question. He says hello to Ruth. Can you expand a little bit on the ACEs science readings for residents during the behavioral health rotation?
Sure. So I have included different articles. Of course, there is Ndidi and Felide's first article from 1998 on the ACEs study at that time that was completed in the San Francisco Bay Area. And then there's some supplemental materials by Nadine Burke-Harris and other authors really highlighting providers' roles in supporting patients with ACEs, how to screen, how to intervene. And so overall, our residents are able to choose what articles they would like to read on the behavioral health rotation. They do have 5 that they need to read, and so one of those 5, I have required them to read Nadine Burke-Harris's book. If he would like, he can certainly email me, and I can send him some of the literature that I have that he might want to review and add to his behavioral health rotation.
Great. Just a couple of minutes left here for some questions. And so Tanya Haynes has a question. During the process, how are you identifying their traditions and norms from trauma when you're doing ACEs? I'm not sure, Tanya, you might need to clarify that question unless the panelists can decipher it. Do you guys have a sense of what Tanya might be getting at here?
So I do have a sense in regards to, in some cultural norms within the United States, we might find them as abusive. That's my assumption.
Okay, yeah, that makes sense.
And at this point in time, from the follow-up psychotherapy side, we don't have enough data to provide a clear answer to that. Has there been anything noticed within the screening process?
I'm still not quite getting the question.
Okay.
Yeah, in some cultures, in our community, we have a very large Asian community, and cupping is a traditional practice. And because of the marks that practice leaves, some people see that as abuse. And so the question may be, how are we differentiating between abuse and these traditional practices. And I think the way the question is asked on the screening helps with that, because it's worded in a very specific way. It doesn't ask you if you've ever experienced abuse. It asks if you've been punched, kicked, those kinds of things. So it's very specific to kind of help root that out. The other interpretation of that question could be alluding to what Dr. Steri was talking about happened this morning when a kiddo was viewing her situation as normal, and how are you ferreting out what they've experienced with that's normal for me. And again, I think that was a perfect example where the ACE questionnaire helped to ferret that out a little bit.
Okay, great. And so we've got just 2 questions left, and one of them is a quickie here. I was actually thinking of this as well. Yesenia has a follow-up. Is the ACE questionnaire available in Spanish?
Yes, it is.
See.
Yes, see.
Beautiful. Very good. And then you probably should, for all the ACE stuff there.
Oh, Naftali, I'm sorry. We lost you. What was that?
Oh, sorry. So do you know the website where you could get the versions of the ACE-Q?
You actually need to contact the Center for Youth Wellness. They have a tab on their website at centerforyouthwellness.org, I believe. And you'll fill out a little form just to let them know that you're interested. And then as soon as you do that, they'll send you the form, and they'll also send you the protocol for how to use it. So it's been super helpful to us to have that, because it includes some of those scripts that you might want to use. But they don't have it publicly available. You do have to contact them directly, and then they'll share that. Great.
And last question here from Holly as we end is an interesting question. She's interested in learning what resources or support you have in place for providers and staff who may be dealing with their own trauma or secondary trauma.
So really, the first line of resources or support is our behavioral health team, and we would certainly be a bridge to get them support within the community. So we really try to not blur that boundary of professionalism within our residency setting, but they could certainly approach me or one of our behavioral health interns at any time to identify any triggers, areas of trigger, anything that may be coming up for them, and we would help them with finding an appropriate fit within the community.
Great, yeah, an important point, because as we address trauma, we also recognize that the ACE, the original ACE study basically told us that this trauma is not respective of socioeconomic class. It cuts across.
In no way,
so, yeah, so we are all subject to the impact of trauma. So thank you very much, Ruth and colleagues. It just has been tremendous. I hope we can have you back again as you continue to develop this work. Thank you so much for the great work you're doing in your state. We really appreciate it. And as I said, we look forward to hearing the continuation of your story. And thanks to all of you who have attended today's webinar as well. Again, if you want to hear this again, look at some of the resources. It'll be up within the next couple of days or so on integratedcarenews.com. If you scroll down to the Vimeo feed, you'll see all of our webinars and other videos posted there as well. Thanks again, and we'll catch you at our next webinar, hopefully in a few weeks, a collaborative webinar with the National Register on immigration in dealing with patients, Latino patients with differing immigration status issues.